Question 1. Process analysis reveals that an audiologist is evaluating a 3-year-old child with suspected hearing loss. The child exhibits some responsiveness to sound during behavioral audiometry, but is difficult to test reliably. The audiologist performs an auditory brainstem response (ABR) test. The ABR results show prolonged latencies and reduced amplitudes at higher stimulus intensities, suggesting a potential auditory pathway issue. Considering the child's age and the limitations of behavioral testing in this population, what is the most appropriate next step in the clinical application of these ABR findings? Option A. Conclude that the child has a significant auditory neuropathy based solely on the prolonged latencies and reduced amplitudes observed in the ABR. Option B. Immediately recommend a specific hearing aid prescription based on the estimated thresholds derived from the ABR latencies and amplitudes without further behavioral verification. Option C. Disregard the ABR results as they are not directly measuring the child's functional hearing and focus solely on improving behavioral testing techniques. Option D. Integrate the ABR findings with the behavioral audiometry and case history to form a comprehensive picture of the child's auditory function, guiding further diagnostic and rehabilitative decisions. Correct answer is D. Integrate the ABR findings with the behavioral audiometry and case history to form a comprehensive picture of the child's auditory function, guiding further diagnostic and rehabilitative decisions. Explanation. Scenario analysis. This scenario presents a common clinical challenge where objective audiological data (ABR) needs to be interpreted in the context of a patient's behavioral responses and developmental stage. Difficulty lies in reconciling potential discrepancies between the two, especially in a young child who cannot provide reliable subjective feedback. The audiologist must exercise careful judgment to ensure the ABR findings are not overinterpreted or misapplied, leading to inappropriate management decisions. Correct approach analysis. The correct approach prioritizes integrating the ABR results with the child's overall audiological profile, including behavioral audiometry and case history. This aligns with best professional practice as outlined by audiology guidelines, which emphasize a comprehensive assessment rather than relying on a single test modality. The ABR provides objective information about the auditory pathway's integrity, but it does not directly measure hearing thresholds in the same way behavioral audiometry does. Therefore, correlating ABR latency and amplitude measures with estimated behavioral thresholds, considering the child's age and developmental status, is crucial for accurate diagnosis and management. This approach ensures that the ABR findings are contextualized and contribute to a holistic understanding of the child's hearing status, leading to appropriate intervention strategies. Incorrect approaches analysis. One incorrect approach would be to solely rely on the ABR latency and amplitude values to definitively establish hearing thresholds without considering behavioral data. This fails to acknowledge the limitations of ABR in directly quantifying hearing sensitivity across all frequencies and can lead to misdiagnosis, particularly in cases of auditory neuropathy, or when the ABR waveform morphology is atypical. This approach disregards the principle of cross-validation of audiological tests, a cornerstone of ethical and competent practice. Another incorrect approach would be to dismiss the ABR findings entirely if they appear to contradict the behavioral audiometry, without further investigation. This could lead to overlooking significant auditory pathway abnormalities that the behavioral tests might not reveal. It also fails to utilize the full diagnostic potential of the ABR, which is invaluable for identifying specific types of hearing loss or neurological involvement. A third incorrect approach would be to use the ABR to predict a specific hearing aid fitting without confirming the behavioral impact. While ABR can provide some guidance, the ultimate goal is to improve functional hearing. Fitting amplification based solely on ABR predictions without behavioral verification can result in suboptimal amplification, patient dissatisfaction, and potentially hinder auditory development. This approach bypasses essential steps in the audiological rehabilitation process. Professional reasoning. Professionals should employ a decision-making framework that begins with a thorough review of the case history and the purpose of the ABR. They should then proceed to analyze the ABR results in conjunction with all available behavioral audiological data. Discrepancies should prompt further investigation, potentially including repeat testing, different ABR paradigms, or referral for further medical evaluation. The ultimate goal is to arrive at a diagnosis that is supported by multiple lines of evidence and leads to a personalized and effective management plan. This systematic, evidence-based approach ensures patient safety and optimal outcomes. Question 2. Investigation of a patient's tympanometric results reveals a flat type B tracing. The patient, however, reports no hearing loss, no ear pain, and no history of recent ear infections. Considering the principles of tympanometry and the Audiology Praxis framework, what is the most appropriate next step in the diagnostic process? Option A. Conclude that the patient's reported symptoms are unreliable and proceed with standard audiometric testing without further investigation into the tympanogram. Option B. Immediately classify the patient as having a significant middle ear abnormality and refer for further medical evaluation based solely on the type B tympanogram. Option C. Assume the tympanometric equipment is malfunctioning and proceed to recalibrate the device before retesting. Option D. Re-examine the patient's case history and consider potential factors that might influence tympanometric findings despite the absence of reported symptoms, such as middle ear effusion that is resolving or a significant difference in middle ear pressure between ears. The correct answer is D. Re-examine the patient's case history and consider potential factors that might influence tympanometric findings despite the absence of reported symptoms, such as middle ear effusion that is resolving or a significant difference in middle ear pressure between ears. Explanation. Scenario analysis. This scenario presents a professional challenge because the audiologist must interpret tympanometric results in the context of a patient's reported symptoms and medical history, rather than relying solely on the graphical output. The challenge lies in distinguishing between a technically accurate tympanogram that may not reflect the patient's actual auditory status and a tympanogram that, while appearing atypical, is consistent with the patient's reported condition. Misinterpretation can lead to delayed or incorrect diagnosis and treatment, impacting patient care and potentially violating professional standards of practice. Correct approach analysis. The correct approach involves a comprehensive interpretation of the tympanogram in conjunction with the patient's subjective complaints and any available audiological history. This aligns with best professional practice as outlined by the Audiology Praxis framework, which emphasizes a holistic assessment. Specifically, the Audiology Praxis guidelines mandate that diagnostic procedures, including tympanometry, are not performed in isolation, but are integrated into a broader clinical picture. This approach ensures that the audiologist considers all relevant factors, leading to a more accurate and patient-centered diagnosis. Ethical considerations under the Audiology Praxis framework also dictate that practitioners must use their professional judgment to synthesize all available data to provide the best possible care. Incorrect approaches analysis. One incorrect approach is to solely rely on the visual classification of the tympanogram, e.g., type A, B, C, without considering the patient's symptoms. This fails to acknowledge that a patient's reported hearing difficulties or ear discomfort might not always present with a textbook tympanometric pattern, or that other factors could influence the results. This approach risks overlooking a genuine underlying pathology or misattributing symptoms to a normal-appearing tympanogram, which is a failure to meet the standard of care expected under audiology praxis. Another incorrect approach is to dismiss atypical tympanometric findings as artifacts or errors without further investigation, especially when the patient reports significant symptoms. The audiology praxis framework encourages thorough investigation of all findings. Dismissing unusual results without due diligence can lead to misdiagnoses and is contrary to the principle of comprehensive patient assessment. A third incorrect approach is to immediately attribute any deviation from a tympanogram, to a specific pathology without considering the full clinical context. While tympanometry is a valuable diagnostic tool, it is not definitive in isolation. Over-reliance on a single interpretation without considering the patient's history, other audiological tests, or potential confounding factors can lead to premature conclusions and inappropriate management, violating the principle of thorough and integrated diagnostic practice. Professional reasoning. When faced with tympanometric results, a professional audiologist should first review the patient's presenting complaints and medical history. Next, they should examine the tympanogram itself, noting its shape, peak pressure, and compliance. The critical step is to synthesize these findings. If the tympanogram appears atypical but the patient reports no symptoms, the audiologist should consider potential causes for the discrepancy, such as ear canal volume variations or recent otitis media. If the tympanogram is atypical and the patient reports symptoms, the audiologist must correlate the findings with the reported symptoms and consider differential diagnoses. This integrated approach, guided by the Audiology Praxis framework, ensures that the patient's individual presentation is central to the diagnostic process, leading to the most appropriate clinical decisions. Question 3. What factors determine the specific audiometric and tympanometric findings indicative of ossicular chain discontinuity, malleus, incus, stapes, versus other forms of middle ear conductive hearing loss? Option A. The patient's subjective report of tinnitus and the presence of nystagmus. Option B. The precise nature of the ossicular disruption, e.g., fixation, dislocation, or fracture of the malleus, incus, or stapes, and its impact on impedance bridging. Option C. The audiologist's personal experience with similar cases and anecdotal evidence from colleagues. Option D. The presence or absence of cerumen impaction and the degree of external auditory canal patency. The correct answer is B. The precise nature of the ossicular disruption, e.g., fixation, dislocation, or fracture of the malleus, incus, or stapes, and its impact on impedance bridging. Explanation. This scenario is professionally challenging because accurately assessing the integrity and function of the ossicular chain requires a nuanced understanding of audiological principles and the ability to interpret various diagnostic findings. The audiologist must synthesize information from otoscopy, tympanometry, acoustic reflexes, and pure tone audiometry to form a comprehensive picture. The challenge lies in differentiating between conductive hearing lost solely due to ossicular discontinuity versus other potential causes of middle ear pathology, and in understanding how the specific type of ossicular disruption impacts the audiogram and tympanogram. The correct approach represents best professional practice because it aligns with the audiology praxis exam's emphasis on evidence-based practice and patient-centered care. It necessitates a thorough diagnostic process that considers the interplay of multiple audiological tests. This comprehensive evaluation allows for precise identification of the nature and extent of ossicular chain involvement, which is crucial for appropriate management recommendations, whether they involve medical referral, surgical consultation, or hearing aid fitting. Adhering to this systematic diagnostic approach ensures that decisions are based on objective data and a deep understanding of middle ear mechanics, thereby maximizing the potential for successful patient outcomes and upholding professional standards of care. An incorrect approach that relies solely on a single test, such as only considering tympanometry results without correlating them with pure tone thresholds and acoustic reflex data, would be a regulatory and ethical failure. This would violate the principle of comprehensive audiological assessment, potentially leading to misdiagnosis and inappropriate treatment plans. It fails to meet the standard of care expected in audiological practice, which mandates the integration of multiple data points. Another incorrect approach might be to assume ossicular discontinuity based on a general pattern of conductive hearing loss without specific evidence from tympanometry, e.g., a flat tympanogram with reduced compliance, or acoustic reflexes, e.g., absent or elevated reflexes. This speculative approach lacks the necessary diagnostic rigor and could lead to unnecessary patient anxiety or delayed appropriate intervention. Ethically, it breaches the duty to provide accurate and thorough evaluations. The professional decision-making process for similar situations should involve a systematic, multifaceted approach. First, gather all available patient history and perform a thorough otoscopic examination. Second, conduct a battery of audiological tests, including pure tone audiometry, tympanometry, and acoustic reflex testing. Third, interpret these results in conjunction, looking for consistent patterns indicative of middle ear pathology and specifically ossicular chain involvement. Fourth, consider differential diagnoses and rule out other potential causes of the observed audiological findings. Finally, formulate a diagnosis and develop a management plan that is evidence-based and tailored to the individual patient's needs, including appropriate referrals when necessary. Question 4. When evaluating a patient who reports significant difficulty understanding speech in noisy environments, despite having normal pure tone hearing thresholds, which approach best reflects the assessment of auditory cortex functions within the audiology praxis framework. Option A. Recommending a broad-spectrum noise generator for use in all listening situations to mask background noise. Option B. Focusing solely on the patient's subjective report of hearing difficulties and recommending a hearing aid trial. Option C. Administering electrophysiological tests that assess the brainstem and cortical responses to auditory stimuli, correlating these findings with the patient's reported difficulties. Option D. Performing a detailed assessment of the peripheral auditory system, including tympanometry and acoustic reflexes, to rule out any middle ear pathology. The correct answer is C. Administering electrophysiological tests that assess the brainstem and cortical responses to auditory stimuli, correlating these findings with the patient's reported difficulties. Explanation: this scenario is professionally challenging because it requires the audiologist to interpret complex neurophysiological data in the context of a patient's subjective auditory complaints, directly relating to the functional integrity of the auditory cortex. The audiologist must go beyond simple audibility thresholds to assess how the brain processes sound, which is crucial for understanding difficulties with speech comprehension in noise, sound localization, and auditory attention. The regulatory framework for audiology praxis emphasizes evidence-based practice and patient-centered care, necessitating a thorough understanding of higher-order auditory processing. The correct approach represents best professional practice because it directly addresses the patient's functional deficits by considering the role of the auditory cortex in processing and interpreting sound. This aligns with the audiology praxis guidelines that mandate comprehensive audiological evaluations, including assessment of central auditory processing when indicated by patient history and presenting complaints. By integrating objective measures of cortical function with the patient's reported experiences, the audiologist can develop a more accurate diagnosis and a targeted, effective management plan. This approach is ethically sound as it prioritizes the patient's well-being and functional outcomes. An incorrect approach that focuses solely on peripheral hearing thresholds fails to acknowledge the potential for central auditory processing disorders, which are often linked to auditory cortex dysfunction. This would be a regulatory failure, as it deviates from the comprehensive evaluation standards expected under audiology praxis, potentially leading to misdiagnosis and inadequate treatment. Another incorrect approach that relies exclusively on subjective patient reports without objective neurophysiological correlates would also be professionally unacceptable. While patient reports are vital, the audiology praxis framework requires objective verification of suspected auditory processing deficits. Without objective data, the audiologist cannot definitively attribute the difficulties to auditory cortex function, leading to a lack of evidence-based support for the diagnosis and treatment plan. A third incorrect approach that involves recommending a generic intervention without a clear understanding of the underlying auditory cortex function would be a significant ethical and regulatory failure. Interventions must be tailored to the specific deficits identified. Recommending treatment without a precise diagnosis based on the functional assessment of the auditory cortex is not evidence-based and could be ineffective or even detrimental to the patient. Professionals should approach such situations by first conducting a thorough case history to identify potential issues related to higher-order auditory processing. This should be followed by a comprehensive audiological assessment, including standard pure-tone audiometry and speech audiometry. If the case history and initial tests suggest central auditory processing difficulties, specific tests designed to evaluate auditory cortex functions, such as dichotic listening tasks, gap detection, or electrophysiological measures like auditory evoked potentials, e.g., P300, should be employed. The results of these objective measures must then be integrated with the patient's subjective complaints to formulate a diagnosis and a personalized management plan, adhering strictly to the evidence-based principles outlined in the audiology praxis regulatory framework. Question 5. Quality control measures reveal that a patient presenting with unilateral tinnitus and a sensation of auditory distortion has undergone a standard audiological assessment including pure-tone audiometry, speech audiometry, and otoacoustic emissions, with all results falling within age-appropriate normal limits. However, the patient continues to report significant subjective auditory disturbances suggestive of retrocochlear pathology. Which of the following diagnostic approaches best aligns with the Audiology Praxis regulatory framework for investigating potential auditory nerve pathway dysfunction in this scenario? Option A. Advise the patient that since all standard audiological tests are normal, their symptoms are likely psychosomatic, and no further audiological investigation is warranted. Option B. Recommend immediate referral for a high-resolution magnetic resonance imaging (MRI) of the internal auditory canals and brainstem to rule out structural abnormalities. Option C. Schedule a comprehensive auditory brainstem response (ABR) testing protocol to assess the integrity of the auditory nerve and brainstem auditory pathways, followed by further investigation if indicated by ABR results. Option D. Re-administer the pure-tone audiometry and speech audiometry tests, assuming the initial results may have been inaccurate due to patient variability. Correct answer is B. Recommend immediate referral for high-resolution magnetic resonance imaging (MRI) of the internal auditory canals and brainstem to rule out structural abnormalities. Explanation: Scenario analysis. This scenario presents a professional challenge because it requires the audiologist to interpret complex neurodiagnostic findings in the context of a patient's subjective auditory complaints. The auditory nerve pathways are intricate, and damage or dysfunction at various points can manifest with similar symptoms, making precise localization and diagnosis difficult. The challenge lies in integrating objective test results with the patient's lived experience and ensuring that the diagnostic approach is both comprehensive and ethically sound, avoiding unnecessary or potentially misleading investigations. Correct approach analysis. The correct approach represents best professional practice because it prioritizes a systematic and evidence-based evaluation of the auditory nerve pathways. This involves utilizing a battery of tests that specifically target different segments of the pathway, from the cochlea to the brainstem. Electrophysiological measures like auditory brainstem response (ABR) are crucial for assessing the integrity of the auditory nerve and brainstem auditory pathways. Otocoustic emissions (O) provide information about outer hair cell function, which can indirectly inform the health of the afferent auditory nerve. Pure-tone audiometry and speech audiometry are foundational for establishing the degree and type of hearing loss, which can then be correlated with neurodiagnostic findings. This multifaceted approach aligns with the Audiology Praxis regulatory framework's emphasis on thorough patient assessment and the ethical obligation to provide accurate diagnoses based on objective and subjective data. It avoids premature conclusions and ensures that all relevant aspects of auditory function are considered. Incorrect approaches analysis. One incorrect approach involves solely relying on pure-tone audiometry and speech audiometry to diagnose auditory nerve pathology. This is professionally unacceptable because these tests primarily assess peripheral hearing function and the central auditory processing capabilities, but they lack the specificity to pinpoint issues within the auditory nerve itself or the brainstem pathways. Regulatory guidelines for audiology praxis mandate a comprehensive evaluation when neurosensory deficits are suspected, and this approach falls short of that standard, potentially leading to misdiagnosis or delayed diagnosis of serious conditions. Another incorrect approach is to immediately proceed with invasive imaging studies, such as MRI, without first conducting appropriate electrophysiological and behavioral audiological assessments. This is ethically problematic due to the potential for unnecessary patient exposure to cost, time, and the risks associated with imaging procedures. It also violates the principle of judicious resource utilization. The Audiology Praxis framework implicitly supports a tiered diagnostic approach, starting with less invasive and more cost-effective audiological tests that can guide the need for further, more specialized investigation. A third incorrect approach is to dismiss the patient's subjective complaints of auditory nerve dysfunction if initial standard audiological tests appear within normal limits. This is a significant ethical failure, as it disregards the patient's experience and can lead to a failure to diagnose conditions that may not be fully captured by routine testing. Best professional practice, guided by ethical principles and regulatory expectations, requires a diligent investigation into all reported symptoms, even if initial findings are equivocal, and may necessitate more specialized neurodiagnostic testing. Professional reasoning. When faced with a patient presenting with symptoms suggestive of auditory nerve pathway involvement, the professional decision-making process should involve 1. Thoroughly gathering the patient's history, focusing on the nature, onset, and progression of auditory symptoms. 2. Conducting a comprehensive audiological evaluation, including pure tone audiometry, speech audiometry, and OAEs. 3. Based on these initial findings and the patient's complaints, determining the necessity and sequence of neurodiagnostic tests, such as ABR, to specifically assess the auditory nerve and brainstem pathways. 4. Integrating all objective and subjective data to formulate a diagnosis and develop an appropriate management plan. 5. If indicated, referring for further medical evaluation or imaging, but only after appropriate audiological investigations have been completed. This systematic, evidence-based, and patient-centered approach ensures adherence to regulatory standards and ethical obligations. Question 6. Process analysis reveals an audiologist has obtained a speech recognition threshold, SRT, of 30 dBHL for a patient, yet the pure tone audiogram, TA, indicates a pure tone average, TA, of 50 dBHL across the speech frequencies. The patient reports significant difficulty understanding speech in quiet environments. Which of the following represents the most appropriate course of action for the audiologist? Option A. Immediately recalibrate the audiometer and retest both the PTA and SRT, assuming a significant equipment malfunction is the cause of the discrepancy. Option B. Accept the SRT of 30 dBHL as accurate, as it aligns with the patient's subjective report of speech understanding difficulties, and proceed with amplification fitting based on this threshold. Option C. Re-administer the SRT, carefully observing the patient's understanding of instructions and response patterns, and consider presenting word recognition scores at a suprathreshold level to corroborate findings. Option D. Disregard the SRT and rely solely on the PTA of 50 dBHL for all subsequent diagnostic and management decisions, as the PTA is considered a more objective measure. The correct answer is C. Re-administer the SRT, carefully observing the patient's understanding of instructions and response patterns, and consider presenting word recognition scores at a suprathreshold level to corroborate findings. Explanation. Scenario analysis. This scenario presents a common challenge in audiology practice, interpreting and acting upon a speech recognition threshold, SRT, that appears inconsistent with other audiological findings, specifically the pure tone audiogram, TA. The professional challenge lies in reconciling these discrepancies to ensure accurate diagnosis and appropriate patient management, adhering to best practices and regulatory guidelines. The audiologist must exercise sound clinical judgment, considering potential sources of error or variability in testing, and understanding the implications of an unreliable SRT for subsequent treatment decisions. Correct approach analysis. The correct approach involves a systematic investigation into the discrepancy. This includes re-evaluating the SRT procedure, ensuring proper instructions were given, the patient understood the task, and the stimuli were appropriate for the patient's suspected hearing loss and cognitive abilities. It also necessitates a thorough review of the PTA, checking for test-retest reliability and potential masking issues. If the discrepancy persists, the audiologist should consider alternative methods for assessing speech understanding, such as word recognition scores, WRS, presented at a suprathreshold level, or even functional hearing assessments. This methodical approach aligns with the audiology praxis regulatory framework's emphasis on accurate assessment, patient-centered care, and evidence-based practice. It ensures that diagnostic conclusions are robust and that treatment plans are based on reliable data, thereby upholding professional standards and patient safety. Incorrect approaches analysis. One incorrect approach is to simply accept the SRT as accurate despite the clear discrepancy with the PTA, and proceed with treatment recommendations based on this potentially flawed data. This represents a failure to adhere to the audiology praxis guidelines regarding thoroughness of assessment and the principle of not making decisions based on unreliable information. It could lead to inappropriate amplification settings or communication strategies, negatively impacting the patient's quality of life and potentially violating ethical obligations to provide competent care. Another incorrect approach is to dismiss the PTA as inaccurate and solely rely on the SRT, especially if the SRT appears to align with the patient's subjective complaints more closely. This ignores the foundational nature of the PTA in audiological assessment and the potential for the SRT to be influenced by factors unrelated to true hearing sensitivity, such as patient fatigue, attention, or understanding of the task. This approach risks misdiagnosing the type and degree of hearing loss, leading to ineffective or even harmful interventions, and contravenes the audiology praxis requirement for comprehensive audiological evaluation. A third incorrect approach is to immediately assume equipment malfunction without first exploring potential patient-related factors or procedural errors. While equipment issues can occur, a systematic investigation should prioritize ruling out more common sources of variability. This premature conclusion can lead to unnecessary recalibration or replacement of equipment, wasting resources and delaying accurate diagnosis, and demonstrates a lack of systematic problem solving, as expected within the audiology praxis framework. Professional reasoning. Professionals should approach discrepancies by first acknowledging the conflict between different test results. The next step is to systematically review the procedures for each test, considering potential sources of error, both technical and patient-related. This involves questioning the validity of the data and seeking clarification through retesting or alternative assessment methods. The decision-making process should be guided by the principle of when in doubt. Investigate further, and always prioritize the patient's best interests by ensuring the most accurate and reliable diagnostic information is obtained before proceeding with management plans. This iterative process of assessment, critical evaluation, and refinement is central to competent audiological practice. Question 7. Strategic planning requires an audiologist to determine the most appropriate diagnostic pathway for a patient presenting with unilateral hearing loss and suspected cochlear dysfunction, considering the potential for exacerbating the condition. Which of the following diagnostic approaches best balances the need for accurate diagnosis with the imperative to minimize risk to the auditory system? Option A. Prescribing a course of broad-spectrum antibiotics and scheduling a follow-up audiogram in 3 months to monitor for spontaneous improvement. Option B. Immediately proceeding with a cochlear implant candidacy evaluation, including electrocochleography, ECOG, and auditory brainstem response (ABR) testing, to assess the extent of neural involvement. Option C. Recommending immediate surgical exploration of the middle ear to identify any structural abnormalities contributing to the hearing loss. Option D. Performing a diagnostic tympanometry and acoustic reflex testing, followed by pure-tone audiometry and speech audiometry, and if indicated, a high-resolution computed tomography (CT) scan of the temporal bone. The correct answer is D. Performing a diagnostic tympanometry and acoustic reflex testing, followed by pure-tone audiometry and speech audiometry, and if indicated, a high-resolution computed tomography (CT) scan of the temporal bone. Explanation. This scenario is professionally challenging because it requires an audiologist to balance the immediate need for diagnostic information with the potential long-term implications of a diagnostic procedure on a patient's auditory health. The audiologist must consider the delicate nature of the auditory system and the potential for iatrogenic effects. Careful judgment is required to select the least invasive yet most informative diagnostic approach. The correct approach represents best professional practice because it prioritizes patient safety and well-being by employing a non-invasive diagnostic method that provides sufficient information to guide further management. This aligns with the ethical principle of beneficence, acting in the patient's best interest, and non-maleficence, avoiding harm. Specifically, it adheres to the audiology praxis regulatory framework's emphasis on evidence-based practice and the judicious use of diagnostic tools, ensuring that interventions are proportionate to the clinical need and minimize risk. An incorrect approach that involves immediate invasive testing, without exhausting less risky alternatives, would represent a failure to adhere to the audiology praxis guidelines on patient care standards and risk management. This could be construed as a breach of professional duty of care, potentially leading to patient harm and regulatory sanctions. Another incorrect approach, such as delaying necessary diagnostic evaluation due to an overestimation of risk from a standard, low-risk procedure, would fail to meet the audiology praxis requirements for timely diagnosis and intervention, potentially compromising patient outcomes and violating the principle of timely care. The professional decision-making process for similar situations should involve a systematic risk-benefit analysis. This includes 1. Clearly defining the clinical question and the information needed. 2. Identifying all potential diagnostic approaches. 3. Assessing the risks and benefits associated with each approach, considering the patient's specific condition and overall health. 4. Consulting relevant audiology praxis guidelines and best practice recommendations. 5. Communicating these options, risks, and benefits clearly to the patient, facilitating informed consent. 6. Selecting the approach that offers the optimal balance of diagnostic yield and patient safety. Question 8. Operational review demonstrates that an audiologist has performed pure-tone audiometry, tympanometry, and acoustic reflex testing on a patient presenting with subjective hearing difficulties. The pure-tone audiometry reveals a mild conductive hearing loss. The tympanometry shows a type B curve with low compliance, and acoustic reflexes are absent bilaterally. Which of the following diagnostic interpretations best reflects the comprehensive assessment of the middle ear status? Option A. The pure-tone audiometry alone is sufficient to diagnose the type and degree of hearing loss. Option B. Absent acoustic reflexes are the primary indicator of middle ear pathology, irrespective of tympanometry results. Option C. The type B tympanogram indicates a possible middle ear abnormality, but further testing is not necessary. Option D. The findings are consistent with a significant middle ear effusion, likely causing the conductive hearing loss. The correct answer is D. The findings are consistent with a significant middle ear effusion, likely causing the conductive hearing loss. Explanation. Scenario analysis. This scenario presents a challenge in differentiating between a true middle ear effusion and a potential artifact or misinterpretation during audiological assessment. The audiologist must rely on a comprehensive understanding of middle ear physiology and the nuances of tympanometry and acoustic reflex testing to accurately diagnose the underlying condition. Misinterpreting these results can lead to inappropriate management, delayed treatment, and potentially negative impacts on the patient's hearing and communication. Correct approach analysis. The correct approach involves a systematic evaluation of all available audiological data, including pure-tone audiometry, tympanometry, and acoustic reflex thresholds. This integrated approach allows for a more definitive diagnosis. Tympanometry, specifically the shape and compliance values of the tympanogram, provides crucial information about the middle ear's mechanical properties. Acoustic reflex testing assesses the integrity of the stapedius muscle reflex pathway, which is highly sensitive to middle ear status. When these tests are interpreted in conjunction, they offer a robust picture of middle ear function. For example, a type B tympanogram with low compliance, coupled with absent or elevated acoustic reflexes, strongly suggests middle ear effusion. This aligns with best professional practice as outlined by audiology guidelines, which emphasize a multifaceted diagnostic approach to ensure accuracy and patient safety. Incorrect approaches analysis. One incorrect approach would be to solely rely on pure-tone audiometry results without considering the middle ear-specific tests. Pure-tone thresholds can be affected by middle ear pathology, but they do not pinpoint the cause. This approach fails to meet the diagnostic standards for middle ear assessment, potentially leading to a misdiagnosis of sensorineural hearing loss when the issue is conductive. Another incorrect approach would be to interpret tympanometry results in isolation, without considering the acoustic reflex thresholds. While a type B tympanogram is indicative of a problem, the absence or elevation of acoustic reflexes provides further corroboration and can help differentiate the severity or specific nature of the middle ear issue. Ignoring this additional data point limits the diagnostic precision. A third incorrect approach would be to assume the presence of middle ear effusion based on a single abnormal finding, such as a slightly reduced compliance on tympanometry, without further investigation or correlation with other tests. This hasty conclusion bypasses the necessary thoroughness in audiological assessment and could lead to unnecessary interventions or patient anxiety. Professional reasoning. Professionals should approach such scenarios by first reviewing the patient's history and presenting complaints. Then, they should systematically conduct and interpret all relevant audiological tests, including pure-tone audiometry, tympanometry, and acoustic reflex testing. The results of these tests should be integrated to form a coherent diagnostic picture. If there is ambiguity, further investigation or referral may be warranted. This methodical process ensures that the diagnosis is accurate, leading to appropriate management strategies and optimal patient outcomes, adhering to the ethical principles of providing competent and comprehensive care. Question 9. System analysis indicates a patient presence for a hearing assessment, and when asked about their ear health, describes their tympanic membrane as perfectly clear and intact. However, during the otoscopic examination, the audiologist observes significant retraction of the tympanic membrane with evidence of fluid in the middle ear space, consistent with otitis media with effusion. The audiologist must decide how to proceed with documenting and communicating these findings. Which of the following approaches best aligns with professional standards and regulatory requirements for audiology praxis? Option A. Immediately dismiss the patient's description as inaccurate and proceed with the assessment without further discussion of their initial statement about their tympanic membrane. Option B. Document the tympanic membrane characteristics solely based on the patient's subjective report of it being perfectly clear and intact, as this reflects the patient's stated perception. Option C. Document the tympanic membrane as clear and intact as reported by the patient, but make a separate note of the audiologist's objective findings without explicitly linking them. Option D. Document the tympanic membrane findings as observed during otoscopy, noting the retraction and presence of middle ear fluid, and then explain these objective findings to the patient in a clear and understandable manner, addressing their initial description. The correct answer is D. Document the tympanic membrane findings as observed during otoscopy, noting the retraction and presence of middle ear fluid, and then explain these objective findings to the patient in a clear and understandable manner, addressing their initial description. Explanation. Scenario analysis. This scenario presents a professional challenge due to a conflict between a patient's stated preference and the audiologist's clinical judgment regarding the interpretation of tympanic membrane characteristics. The audiologist must navigate the ethical obligation to respect patient autonomy while upholding professional standards of care and ensuring accurate diagnosis and treatment planning. The potential for misinterpretation of tympanic membrane findings, especially in the presence of subtle or atypical presentations, necessitates careful consideration and communication. Correct approach analysis. The correct approach involves a thorough and objective assessment of the tympanic membrane, documenting all observed characteristics, and then engaging in a clear, patient-centered discussion. This approach aligns with the audiology praxis regulatory framework, which emphasizes evidence-based practice, accurate documentation, and informed patient consent. By thoroughly examining and documenting the tympanic membrane, the audiologist adheres to professional standards for diagnostic procedures, explaining the findings in understandable terms, even if they contradict the patient's perception, respects patient autonomy by providing them with accurate information to make informed decisions. This also fulfills the ethical duty to provide competent care and avoid misdiagnosis. Incorrect approaches analysis. One incorrect approach involves immediately accepting the patient's subjective description of their tympanic membrane without independent clinical verification. This fails to uphold the professional standard of objective assessment and could lead to an inaccurate diagnosis if the patient's perception is not aligned with the physical findings. It also risks undermining the audiologist's expertise and the integrity of the diagnostic process, potentially violating regulatory requirements for accurate record-keeping and diagnostic procedures. Another incorrect approach is to dismiss the patient's description outright and proceed with a diagnosis based solely on the audiologist's findings, without acknowledging or attempting to understand the patient's perspective. This demonstrates a lack of patient-centered care and can erode trust. Ethically, it fails to respect patient autonomy and can be perceived as condescending, potentially leading to patient dissatisfaction and non-adherence to recommendations. It also misses an opportunity to explore potential underlying reasons for the patient's perception, which might offer additional diagnostic clues. A third incorrect approach is to document the tympanic membrane characteristics solely based on the patient's subjective report, even if it contradicts the audiologist's objective findings. This represents a significant failure in professional integrity and diagnostic accuracy. It violates the fundamental principle of objective clinical assessment and leads to fraudulent or misleading documentation, which is a direct contravention of regulatory requirements for accurate patient records and professional conduct, professional reasoning. Professionals should approach such situations by prioritizing objective clinical assessment. This involves a systematic examination and detailed documentation of all observable findings. Following this, a crucial step is to engage in open and empathetic communication with the patient, explaining the audiologist's findings in clear, non-technical language. If there is a discrepancy between the patient's perception and the objective findings, the audiologist should explore the reasons for this difference, validating the patient's experience while gently guiding them towards an understanding of the clinical reality. This collaborative approach ensures that the patient feels heard and respected, while also guaranteeing that diagnostic and treatment decisions are based on accurate, objective data, thereby upholding both ethical and regulatory obligations. Question 10. The audit findings indicate that a significant number of patients presenting with suspected hearing loss are undergoing a limited range of audiological tests, raising concerns about the thoroughness of the diagnostic process. Considering the need for accurate and comprehensive audiological evaluations, which of the following approaches best aligns with established professional standards and regulatory expectations for hearing assessment techniques? Option A. Conducting only pure tone audiometry without considering the need for speech audiometry or emittance testing, regardless of the patient's presentation. Option B. Primarily utilizing screening audiometry for all patients, with referral for further testing only if the screening results are clearly abnormal. Option C. Relying solely on emittance testing to assess middle ear function and inferring peripheral hearing sensitivity from these results. Option D. Employing a tiered approach to assessment, starting with basic screening and progressing to more specialized diagnostic tests based on initial findings and patient characteristics. Correct answer is D. Employing a tiered approach to assessment, starting with basic screening and progressing to more specialized diagnostic tests based on initial findings and patient characteristics. Explanation. The audit findings indicate a need to review the application of hearing assessment techniques in a clinical setting. This scenario is professionally challenging because the audiologist must balance the need for accurate diagnostic information with patient comfort, cooperation, and the efficient use of clinical resources. The choice of assessment technique is not arbitrary. It must be guided by the patient's age, cognitive status, suspected audiological condition, and the specific diagnostic question being addressed. Adherence to established audiological protocols and ethical guidelines is paramount to ensure patient safety and the validity of the assessment results. The correct approach represents best professional practice because it prioritizes a comprehensive and individualized assessment strategy. This involves selecting techniques that are appropriate for the patient's presentation and the clinical question, ensuring that the results are reliable and valid. For example, using pure tone audiometry with appropriate masking when indicated, or employing speech audiometry to assess functional hearing, are fundamental to a thorough audiological evaluation. These techniques are supported by professional standards and regulatory guidelines that mandate evidence-based practice and patient-centered care. An incorrect approach, such as solely relying on screening audiometry for diagnostic purposes, fails to meet the standards for a comprehensive audiological assessment. Screening tests are designed to identify individuals who may have a hearing problem and require further evaluation. They are not intended to provide detailed diagnostic information. This approach would be a regulatory and ethical failure as it could lead to misdiagnosis, delayed treatment, and inadequate patient management, violating the principle of providing competent and appropriate care. Another incorrect approach, such as neglecting to perform emittance testing when indicated, could miss crucial information about middle ear function, which is essential for accurate diagnosis and management of hearing loss. This omission would be a failure to adhere to best practices and could compromise the diagnostic integrity of the assessment, potentially leading to inappropriate recommendations. Professionals should employ a decision-making framework that begins with a thorough case history and otoscopic examination. This initial assessment informs the selection of appropriate diagnostic tools. The audiologist must then consider the patient's ability to participate in the testing, the potential need for specialized techniques, e.g., play audiometry for children or electrophysiological tests for non-organic hearing loss, and the necessity of masking to ensure accurate results. Throughout the process, communication with the patient and adherence to established protocols are critical for ensuring a valid and ethical audiological assessment. Question 11. Process analysis reveals that a patient presents with subjective difficulties understanding speech in noisy environments and localizing sounds, despite having normal pure-tone audiometry and tympanometry results. A recent MRI scan shows a small lesion in the right temporoparietal junction. Considering the neuroanatomy of hearing, which of the following diagnostic approaches best addresses the patient's reported symptoms and imaging findings? Option A. Conclude that the patient's symptoms are likely psychosomatic given the normal peripheral audiological results and the small size of the MRI lesion. Option B. Recommend further investigation into central auditory processing disorders, correlating the lesion's location with known auditory pathways and potential functional deficits. Option C. Advise the patient that their symptoms are not audiological in nature and suggest they seek consultation with a different medical specialist. Option D. Focus solely on the MRI findings, assuming the lesion directly explains the reported auditory difficulties without further audiological testing. The correct answer is B. Recommend further investigation into central auditory processing disorders, correlating the lesion's location with known auditory pathways and potential functional deficits. Explanation. Scenario analysis. This scenario presents a professional challenge in audiology practice due to the complexity of interpreting neuroanatomical findings in relation to a patient's reported hearing difficulties. Differentiating between peripheral auditory system dysfunction and central auditory processing disorder, CAPT, requires a nuanced understanding of the auditory pathway's neuroanatomy and the potential impact of lesions or abnormalities at various levels. Misinterpretation can lead to incorrect diagnoses, inappropriate treatment plans, and ultimately, suboptimal patient outcomes. The challenge lies in integrating subjective patient complaints with objective audiological and neuroimaging data, demanding a high level of clinical reasoning and knowledge of neuroanatomy. Correct approach analysis. The correct approach involves a systematic evaluation of the auditory pathway from the cochlea to the auditory cortex, considering the specific neuroanatomical structures involved at each stage. This includes understanding how damage to the cochlea, auditory nerve, brainstem nuclei, e.g., cochlear nuclei, superior olivary complex, midbrain structures, e.g., inferior colliculus, thalamus, medial geniculate body, and auditory cortex can manifest as distinct auditory deficits. By correlating the location and nature of any identified neuroanatomical abnormalities with the patient's reported symptoms and audiological test results, the audiologist can accurately pinpoint the site of lesion and differentiate between peripheral and central auditory dysfunction. This aligns with best professional practice by ensuring a comprehensive and evidence-based diagnostic process, leading to targeted and effective management strategies. Regulatory frameworks for audiology practice emphasize the importance of accurate diagnosis and appropriate patient care, which necessitates a thorough understanding of neuroanatomy. Incorrect approaches analysis. An approach that solely focuses on peripheral auditory function, such as interpreting pure-tone audiometry and tympanometry without considering central auditory pathways, is incorrect. This fails to account for potential CAPT, where peripheral hearing may be normal, but the brain's ability to process sound is impaired. This violates the ethical obligation to provide a complete audiological assessment and can lead to a misdiagnosis of functional hearing loss or an untreated CAPT. An approach that overemphasizes the findings of a single neuroimaging modality without correlating them with audiological data is also incorrect. Neuroimaging may reveal structural abnormalities, but these do not always directly translate to specific auditory deficits without audiological confirmation. For example, a small lesion in the auditory cortex might be present but not clinically significant for hearing if the auditory pathways are otherwise intact and processing is normal. This approach risks overinterpreting incidental findings and failing to address the patient's actual auditory concerns. An approach that dismisses the patient's subjective complaints because objective audiological tests appear within normal limits without further investigation into central processing is incorrect. This disregards the patient's lived experience and the potential for subtle or complex auditory processing issues that may not be captured by standard peripheral tests. It can lead to patient dissatisfaction and a failure to identify treatable conditions. Professional reasoning. Professionals should adopt a systematic, multifaceted approach. This involves 1. Thorough case history taking to understand the nature and impact of the auditory complaints. 2. Comprehensive audiological assessment, including tests sensitive to central auditory processing, e.g., dichotic listening, temporal processing, speech and noise. 3. Careful review of any available neuroimaging, understanding the specific anatomical structures and their roles in audition. 4. Integration of all data to form a differential diagnosis, considering both peripheral and central etiologies. 5. Consultation with other professionals, e.g., neurologists, speech-language pathologists, when indicated. This decision-making process ensures that all relevant factors are considered, leading to the most accurate diagnosis and appropriate patient management, adhering to professional standards and ethical obligations. Question 12. Cost-benefit analysis shows that implementing specific protocols to account for potential middle ear muscle contractions during audiological assessments is more effective than standard interpretation alone. Which of the following approaches best reflects this principle in practice? Option A. Assuming that any unusual acoustic reflex patterns are indicative of neurological compromise and referring the patient for immediate neurological consultation. Option B. Disregarding any observed fluctuations in impedance during tympanometry as insignificant noise and proceeding with standard interpretation of the final tracing. Option C. Immediately escalating to advanced imaging techniques if tympanometry reveals any deviation from a classic type A curve, regardless of other clinical findings. Option D. Routinely incorporating brief periods of quiet observation and repeated acoustic reflex testing at varying intensities when initial reflex thresholds appear atypical or absent, to differentiate between genuine pathology and muscle artifact. The correct answer is D. Routinely incorporating brief periods of quiet observation and repeated acoustic reflex testing at varying intensities when initial reflex thresholds appear atypical or absent, to differentiate between genuine pathology and muscle artifact. Explanation. Scenario analysis. This scenario presents a challenge in balancing diagnostic efficiency with patient comfort and the potential for misinterpretation of findings. The middle ear muscles, specifically the tensor tympani and stapedius, play a crucial role in acoustic reflexes and sound attenuation. Their involuntary contractions can influence tympanometry and acoustic reflex testing, potentially leading to atypical results that might be misinterpreted as pathology if not properly understood and managed. The professional challenge lies in distinguishing between genuine middle ear dysfunction and transient muscular interference. Correct approach analysis. The correct approach involves recognizing the potential influence of middle ear muscle activity on test results and implementing strategies to mitigate or account for it. This aligns with best professional practice by ensuring the accuracy and reliability of diagnostic assessments. Specifically, understanding the physiological role of these muscles and their potential to contract involuntarily, e.g., due to startling stimuli or even during certain phases of testing, allows the audiologist to interpret tympanometric shapes and acoustic reflex thresholds appropriately. This proactive approach minimizes the risk of misdiagnosis and unnecessary further investigations, ultimately benefiting the patient by providing a more precise assessment of their auditory status. This adheres to the principles of competent audiological practice, emphasizing thoroughness and accurate interpretation within the established professional scope. Incorrect approaches analysis. One incorrect approach involves proceeding with standard interpretation of tympanometric and acoustic reflex data without considering or attempting to address potential middle ear muscle contractions. This fails to meet the standard of care by potentially leading to misinterpretation. For instance, a tympanogram with absent or elevated acoustic reflexes could be mistakenly attributed to stapedial or ossicular chain dysfunction, when in fact, involuntary stapedius contraction during reflex testing might be suppressing the reflex. This violates the ethical obligation to provide accurate diagnostic information. Another incorrect approach is to immediately assume pathology and recommend invasive or costly follow-up procedures solely based on atypical results that could be explained by middle ear muscle activity. This is professionally unsound, as it bypasses a simpler, physiological explanation and can lead to unnecessary patient anxiety and financial burden. It demonstrates a lack of critical thinking and adherence to diagnostic best practices, which prioritize ruling out common physiological variations before escalating to more complex diagnostic pathways. A further incorrect approach is to disregard the influence of middle ear muscles entirely, assuming they are always quiescent during testing. This demonstrates a fundamental misunderstanding of auditory physiology, and its impact on audiological assessments can lead to a systematic bias in interpreting results, particularly in individuals prone to muscle tension or those who exhibit startle responses. This failure to account for physiological variables compromises the integrity of the audiological evaluation. Professional reasoning. Professionals should employ a systematic approach that includes a thorough case history to identify potential contributing factors, e.g., anxiety, recent loud noise exposure. During testing, they should be vigilant for signs of muscle artifact, e.g., fluctuating impedance during tympanometry, unusual reflex patterns. If suspected, strategies such as repeated testing, attempting to elicit reflexes at different frequencies or intensities, or even considering a brief period of quiet rest for the patient can be employed. The decision-making process should prioritize accurate interpretation based on a comprehensive understanding of auditory physiology and the potential impact of involuntary muscle activity, ensuring that diagnostic conclusions are robust and clinically meaningful. Question 13. Governance review demonstrates that an audiologist consistently interprets tympanometric peak pressure, TPP, values falling outside the typical range of -100 to +50 dA as definitive indicators of middle ear pathology, without further corroboration. Which of the following approaches best aligns with the regulatory framework and ethical guidelines for audiology praxis in assessing such findings? Option A. Correlating the emittance findings with the patient's case history, otoscopic examination, and pure-tone audiometry results to form a comprehensive diagnostic impression. Option B. Assuming that any TPP value outside the typical range automatically indicates a middle ear effusion or other pathology requiring immediate intervention. Option C. Immediately recommending further invasive diagnostic procedures for all patients exhibiting TPP values outside the typical range. Option D. Interpreting abnormal TPP values in isolation, as this parameter is considered the most critical indicator of middle ear status in emittance audiometry. The correct answer is A. Correlating the emittance findings with the patient's case history, otoscopic examination, and pure-tone audiometry results to form a comprehensive diagnostic impression. Explanation. Scenario analysis. This scenario presents a professional challenge stemming from the potential for misinterpretation of emittance audiometry results, particularly when dealing with tympanometric peak pressure, TPP, values that fall outside the typical range. The audiologist must balance the need for accurate diagnosis and appropriate patient management with the inherent variability in middle ear function and the potential for confounding factors. The challenge lies in distinguishing between a genuine pathological condition requiring intervention and a benign variation that may not necessitate further action, all while adhering to established clinical protocols and regulatory guidelines. Correct approach analysis. The correct approach, which involves correlating the emittance findings with the patient's case history, otoscopic examination, and pure-tone audiometry results, represents best professional practice. This holistic approach is mandated by audiology praxis guidelines which emphasize comprehensive patient assessment. Specifically, regulatory frameworks for audiology praxis require audiologists to integrate all available diagnostic data to form a coherent clinical picture. Relying solely on a single parameter, such as TPP, without considering other clinical indicators, would be a deviation from these standards. This integrated approach ensures that the interpretation of emittance data is contextualized, leading to more accurate diagnoses and appropriate management plans, thereby upholding the standard of care expected of a licensed audiologist. Incorrect approach is analysis. Interpreting abnormal TPP values in isolation without considering other clinical data is a significant regulatory and ethical failure. It bypasses the requirement for a comprehensive audiological assessment, which is a cornerstone of professional practice and often explicitly stated in regulatory codes. This approach risks misdiagnosis, leading to unnecessary patient anxiety, further testing, or delayed treatment for actual conditions. It also fails to meet the ethical obligation to provide patient-centered care based on a thorough evaluation. Assuming that any TPP value outside the typical range automatically indicates a middle ear effusion or other pathology is another regulatory and ethical failure. This oversimplification ignores the wide range of normal TPP values that can occur due to individual anatomical variations, atmospheric pressure changes, or even minor ear canal obstructions that do not represent disease. Such an assumption leads to overtreatment and can erode patient trust. Deciding to proceed with further invasive diagnostic procedures solely based on an isolated abnormal TPP, without first attempting to corroborate the finding with less invasive and more comprehensive audiological assessments, constitutes a failure to adhere to the principle of least harm and efficient resource utilization, which are implicit in professional audiology standards. It also neglects the requirement to establish a clear diagnostic rationale supported by multiple data points. Professional reasoning. Professionals should adopt a systematic decision-making process when interpreting emittance audiometry. This begins with a thorough review of the patient's presenting complaint and medical history. Next, a visual inspection of the ear canal and tympanic membrane via otoscopy is crucial to identify any obvious abnormalities. Emittance results, including tympanometric peak pressure, compliance, and volume, should then be analyzed in conjunction with the pure-tone audiogram. Any discrepancies or findings that do not align with the overall clinical picture should prompt further investigation or careful consideration of potential confounding factors. The decision-making process should always prioritize a comprehensive, evidence-based approach that ensures patient safety and diagnostic accuracy, in line with all applicable regulatory and ethical guidelines. Question 14. The efficiency study reveals that the precise mechanics of the basilar membrane's tonotopic organization and the amplification role of outer hair cells are critical for accurate frequency perception and sound detection at low intensities. Which of the following audiological actions best reflects the direct application of this understanding to patient assessment and management? Option A. Prioritizing electrophysiological tests of the auditory nerve and brainstem to evaluate signal transmission integrity beyond the cochlea. Option B. Accurately interpreting pure-tone audiometry results to identify the degree and configuration of hearing loss, and selecting appropriate hearing aid amplification strategies that leverage cochlear processing capabilities. Option C. Recommending vestibular function tests to assess balance disorders, as these can sometimes co-occur with cochlear pathologies. Option D. Focusing diagnostic efforts on the external auditory canal and middle ear impedance measures to assess the integrity of sound conduction to the inner ear. The correct answer is B. Accurately interpreting pure-tone audiometry results to identify the degree and configuration of hearing loss, and selecting appropriate hearing aid amplification strategies that leverage cochlear processing capabilities. Explanation. The efficiency study reveals a potential disconnect between the understanding of cochlear mechanics and the practical application of audiological interventions. This scenario is professionally challenging because it requires audiologists to not only possess theoretical knowledge of the cochlea's intricate structure and function, but also to translate this understanding into effective patient care, diagnostic accuracy, and appropriate treatment recommendations. Misinterpreting or inadequately applying this knowledge can lead to misdiagnosis, ineffective rehabilitation, and ultimately, suboptimal patient outcomes. Careful judgment is required to bridge the gap between scientific understanding and clinical practice, ensuring that interventions are evidence-based and tailored to individual patient needs. The correct approach represents best professional practice because it directly links the study's findings to the core responsibilities of an audiologist. Understanding the precise role of the basilar membrane's tonotopic organization in frequency discrimination and the function of outer hair cells in amplifying low-intensity sounds is fundamental to interpreting audiometric results, identifying the site of lesion, and selecting appropriate amplification strategies. This approach aligns with the ethical imperative to provide competent and evidence-based care, ensuring that diagnostic and rehabilitative efforts are grounded in a thorough understanding of auditory physiology. Regulatory frameworks, such as those governing audiology practice, mandate that practitioners maintain current knowledge and apply it effectively to patient care. An incorrect approach that focuses solely on the outer ear's role in sound transmission fails to address the core findings related to the cochlea. This represents a regulatory and ethical failure because it demonstrates a lack of understanding of the specific area of auditory processing highlighted by the study and neglects the primary site of sensory transduction for hearing. It is professionally unacceptable as it leads to an incomplete diagnostic assessment and potentially inappropriate treatment plans, violating the duty of care owed to patients. Another incorrect approach that prioritizes the auditory nerve signal transmission without considering the cochlear processing that shapes that signal is also professionally unacceptable. This is a regulatory and ethical failure because it bypasses a critical stage of auditory analysis within the cochlea, where frequency and intensity coding are refined. This oversight can lead to misinterpretations of sensorineural hearing loss, failing to differentiate between cochlear and retrocochlear pathologies, and thus hindering the selection of the most effective interventions. A further incorrect approach that focuses on the central auditory pathways in the brainstem and beyond, while important for auditory processing, is a regulatory and ethical failure in this context. The study's focus is on the cochlea, diverting attention to higher-level processing without first accurately assessing and understanding the cochlear function, represents a failure to address the specific findings of the efficiency study, and can lead to diagnostic errors by attributing problems to central pathways that may originate within the cochlea. The professional decision-making process for similar situations should involve a systematic approach. First, thoroughly understanding the implications of new research or study findings. Second, critically evaluating how these findings relate to established audiological principles and the specific needs of the patient. Third, integrating this knowledge into diagnostic protocols and treatment planning. And fourth, continuously seeking professional development to maintain and enhance competence in all areas of audiology, particularly those highlighted by emerging research. Question 15. The evaluation methodology shows that otocoustic emissions, O, are being utilized to assess cochlear function in a pediatric patient presenting with suspected auditory processing difficulties, alongside standard behavioral audiometry. Considering the clinical application of OAEs, which of the following best describes the appropriate role of OAEs in this diagnostic scenario? Option A. OAEs are considered a screening tool only and should not be used in the diagnostic process for any auditory disorder, regardless of the patient population. Option B. OAEs are primarily used to assess the middle ear's contribution to sound transmission and are not relevant for evaluating cochlear function. Option C. OAEs are the sole diagnostic tool required to confirm auditory processing disorder, as they directly measure the brain's interpretation of sound. Option D. OAEs are used to objectively assess the integrity of the outer hair cells in the cochlea, providing complementary data to behavioral audiometry for a more comprehensive understanding of auditory pathway function, especially when behavioral responses may be unreliable or difficult to obtain. The correct answer is D. OAEs are used to objectively assess the integrity of the outer hair cells in the cochlea, providing complementary data to behavioral audiometry for a more comprehensive understanding of auditory pathway function, especially when behavioral responses may be unreliable or difficult to obtain. Explanation. Scenario analysis. This scenario presents a common challenge in audiology practice, selecting the most appropriate diagnostic tool for a specific clinical question. The professional must balance the efficiency of screening with the diagnostic accuracy required for effective patient management, all while adhering to established clinical guidelines and ethical considerations for patient care. The challenge lies in interpreting the nuances of OAE results in the context of a broader audiological assessment and patient history. Correct approach analysis. The correct approach involves utilizing OAEs as a complementary tool to a comprehensive audiological assessment, particularly when investigating specific auditory pathway functions or screening for hearing loss in challenging populations. This aligns with best professional practice as outlined by audiology standards, which emphasize a multifaceted approach to diagnosis. OAEs provide objective physiological data that can corroborate behavioral audiometric findings, aid in differential diagnosis, e.g., distinguishing cochlear from retrocochlear pathology, and serve as a valuable screening tool for infants and non-cooperative individuals. Their use is justified when the clinical question demands objective measures of cochlear function, contributing to a more complete and accurate diagnostic picture without replacing the need for behavioral testing when feasible. Incorrect approaches analysis. One incorrect approach is relying solely on OAEs for a definitive diagnosis of hearing loss without any behavioral audiometric confirmation. This fails to meet the standard of care by neglecting essential diagnostic components. Regulatory frameworks and ethical guidelines mandate a comprehensive assessment to ensure accurate diagnosis and appropriate management. Sole reliance on OAEs can lead to misdiagnosis, particularly in cases of non-organic hearing loss, or when the OAE results are borderline or uninterpretable due to external factors. Another incorrect approach is to dismiss OAEs entirely as a screening tool, without considering their specific diagnostic utility in certain populations or for specific pathologies. This overlooks the established role of OAEs in early detection and monitoring of cochlear function, as supported by professional guidelines. Failing to utilize OAEs when indicated for specific patient groups, e.g., infants, individuals with suspected ototoxicity, represents a failure to provide optimal patient care and may violate ethical obligations to employ all relevant diagnostic resources. A third incorrect approach is to interpret OAE results in isolation, without considering the patient's case history, otoscopic findings, or other audiological test results. This demonstrates a lack of integrated diagnostic reasoning. Professional practice requires a holistic interpretation of all available data to form a coherent diagnostic impression. Ignoring contextual information can lead to misinterpretation of OAE findings and subsequent inappropriate management decisions, which is a breach of professional responsibility. Professional reasoning. Professionals should approach OAE utilization by first identifying the specific clinical question being addressed. This involves considering the patient's age, history, presenting complaints, and any initial screening results. Next, they should consult current audiology practice guidelines and literature to determine the established role and limitations of OAEs in addressing that specific question. The decision to use OAEs should be based on whether they will provide objective, complementary information that enhances diagnostic accuracy or efficiency. If OAEs are employed, their results must be interpreted within the context of the entire audiological assessment and patient presentation. This systematic approach ensures that diagnostic tools are used appropriately, ethically, and in accordance with best practices for patient care. Question 16. The monitoring system demonstrates a consistent pattern of audiometric thresholds that fall within the normal hearing range across all tested frequencies for a particular client. However, the client consistently reports significant difficulties with understanding speech in noisy environments and expresses frustration with everyday communication. Which of the following represents the most appropriate next step in the audiological assessment process? Option A. Conclude that the client's hearing is within normal limits and that their reported difficulties are likely due to other factors, discontinuing further audiological investigation. Option B. Immediately refer the client for a psychological evaluation to assess for non-organic hearing loss, given the discrepancy between objective findings and subjective reports. Option C. Focus solely on the objective audiometric data, reassuring the client that their hearing is normal and that they should be able to hear adequately. Option D. Proceed with recommending assistive listening devices and communication strategies based on the client's reported difficulties, while scheduling further diagnostic evaluations to explore potential underlying causes. The correct answer is D. Proceed with recommending assistive listening devices and communication strategies based on the client's reported difficulties, while scheduling further diagnostic evaluations to explore potential underlying causes. Explanation. The monitoring system demonstrates a consistent pattern of audiometric thresholds that fall within the normal hearing range across all tested frequencies for a particular client. This scenario is professionally challenging because it requires the audiologist to move beyond simply recording data and to critically evaluate the client's reported subjective experience against objective findings. The audiologist must consider potential discrepancies and ensure that the client's overall well-being and communication needs are met, even when objective measures appear normal. The correct approach represents best professional practice because it prioritizes a holistic understanding of the client's hearing status and its impact on their life. This involves a thorough case history, consideration of the client's reported difficulties, and a comprehensive assessment that may include speech audiometry, emittance testing, and potentially electrophysiological measures, all interpreted within the context of the client's functional hearing. This approach aligns with the ethical principles of patient-centered care and the professional standards of audiology practice, which mandate that audiologists address the functional impact of hearing, not just isolated test results. The Audiology Praxis framework emphasizes the importance of integrating objective data with subjective reports to provide comprehensive audiological care. An incorrect approach that relies solely on the normal audiometric thresholds without further investigation fails to acknowledge the possibility of non-organic hearing loss, auditory processing disorders, or other factors that can affect communication despite normal pure-tone thresholds. This approach represents a regulatory and ethical failure by potentially overlooking a client's genuine hearing difficulties, leading to inadequate or inappropriate management. It violates the principle of beneficence by not acting in the client's best interest and could be seen as a failure to adhere to professional standards of care as outlined by the Audiology Praxis guidelines, which expect a thorough and individualized assessment. Another incorrect approach that immediately assumes malingering based on normal thresholds without exploring all other possibilities is also professionally unacceptable. This demonstrates a lack of clinical reasoning and can be detrimental to the client-therapist relationship. It is an ethical failure to prejudge a client and can lead to a denial of necessary services or support. The professional decision-making process for similar situations should involve a systematic approach. 1. Thoroughly review the case history and client's reported symptoms. 2. Critically analyze all objective test results, looking for consistency and potential discrepancies. 3. Consider differential diagnoses that could explain the reported symptoms despite normal objective findings, e.g., auditory processing disorder, non-organic hearing loss, central auditory dysfunction. 4. Employ additional diagnostic tools and techniques as indicated by the initial assessment. 5. Engage in open and empathetic communication with the client to understand their perspective and concerns. 6. Formulate a management plan that addresses the client's functional hearing needs and reported difficulties, even if further investigation is required. Question 17. The efficiency study reveals that some audiologists are inconsistently recording the specific stimulus frequencies and presentation levels utilized when obtaining acoustic reflexes, particularly when abnormal responses are observed. Which of the following documentation practices best aligns with the regulatory framework for audiology praxis concerning acoustic reflex testing? Option A. Documenting the specific stimulus frequencies and presentation levels for all tested ears, noting the presence or absence of a reflex at each parameter. Option B. Recording only the presence or absence of a reflex for the ear being tested, assuming standard parameters were used. Option C. Noting abnormal reflex findings without specifying the stimulus parameters that elicited them. Option D. Documenting the stimulus parameters only for abnormal reflex findings, omitting details for normal responses. The correct answer is A. Documenting the specific stimulus frequencies and presentation levels for all tested ears, noting the presence or absence of a reflex at each parameter. Explanation. The efficiency study reveals that a significant number of audiologists are not consistently documenting the specific parameters used during acoustic reflex testing, particularly in cases where abnormal results are obtained. This scenario is professionally challenging because accurate and complete documentation is fundamental to patient care, legal defensibility, and adherence to professional standards. Without precise parameter recording, it becomes difficult to track changes over time, compare results with previous assessments, or provide clear justification for diagnostic conclusions and subsequent management plans. This lack of detail can also impede effective communication with other healthcare professionals involved in the patient's care. The correct approach, which involves meticulously documenting all tested frequencies, intensity levels, and the presence or absence of a reflex for each ear, represents best professional practice. This aligns with the Audiology Praxis regulatory framework's emphasis on comprehensive record keeping, ensuring that patient evaluations are thorough, reproducible, and transparent. Such detailed documentation is crucial for demonstrating adherence to established diagnostic protocols and for providing a robust basis for clinical decision-making, thereby upholding the audiologist's professional responsibility and safeguarding patient interests. An incorrect approach would be to only note the presence or absence of a reflex without specifying the stimulus parameters. This fails to meet the audiology praxis requirements for detailed record keeping, as it omits critical information necessary for interpreting the results. Ethically, this omission could lead to misinterpretations of the patient's auditory pathway function and potentially delay or misdirect appropriate treatment. Another incorrect approach is to assume that standard parameters were used and not record them, which is a direct violation of the principle of accurate and complete documentation mandated by professional guidelines. This lack of specificity undermines the reliability of the assessment and can be problematic in legal or peer review situations. A further incorrect approach is to only document abnormal findings, neglecting to record the parameters for normal reflexes as well. While abnormal findings are critical, the complete record should reflect all tested conditions to provide a comprehensive picture of the auditory system's response. Professionals should employ a decision-making process that prioritizes thoroughness and adherence to regulatory mandates. This involves a systematic review of the Audiology Praxis guidelines for documentation standards before and after each assessment. When faced with a situation where documentation might be incomplete, the professional should pause and consider the potential impact on patient care, continuity of care, and legal implications. The guiding principle should always be to create a record that is as detailed and informative as possible, anticipating the needs of future clinicians and ensuring accountability. Question 18. Assessment of a patient's tympanometric results reveals a flat tracing type B in the left ear, with a peak pressure reading outside the normal range. The audiologist has confirmed proper probe placement and equipment calibration. Considering the principles of tympanometry and best practice within the Audiology Praxis framework, which of the following represents the most appropriate next step in the assessment process? Option A. Immediately conclude that the patient has a significant middle ear effusion and schedule them for a referral to an otolaryngologist without further investigation. Option B. Re-examine the patient's case history for any contributing factors and consider repeating the tympanometry after a brief rest period, while also preparing for further diagnostic audiological evaluations based on the initial findings. Option C. Document the flat tracing as a normal variant and continue with the rest of the audiological assessment, disregarding the abnormal pressure reading. Option D. Assume the tympanometric equipment is malfunctioning and proceed with testing the other ear without addressing the abnormal reading in the left ear. The correct answer is B. Re-examine the patient's case history for any contributing factors and consider repeating the tympanometry after a brief rest period, while also preparing for further diagnostic audiological evaluations based on the initial findings. Explanation. The scenario presents a common clinical challenge where a patient exhibits atypical tympanometric results, necessitating a thorough understanding of the underlying principles to accurately interpret the findings and guide further management. The professional challenge lies in differentiating between genuine pathological conditions and artifacts or misinterpretations of the data, ensuring patient safety and appropriate care. The correct approach represents best professional practice because it prioritizes a systematic, evidence-based evaluation of the tympanometric data in conjunction with the patient's clinical presentation. This aligns with the Audiology Praxis regulatory framework, which mandates that audiologists conduct comprehensive assessments and make informed clinical decisions based on a holistic understanding of the patient's audiological status. Adhering to established protocols for tympanometry, including proper probe placement, calibration, and interpretation of pressure, volume, and compliance measures, is essential for diagnostic accuracy and patient well-being. This approach ensures that the audiologist is not making assumptions, but rather systematically investigating potential causes for the observed results, thereby upholding professional standards of care and ethical responsibility. An incorrect approach that relies solely on a single atypical reading without considering other factors or repeating the test would be professionally unacceptable. This could lead to misdiagnosis, unnecessary further testing, or delayed appropriate treatment, violating the ethical obligation to provide competent and diligent care. Such an approach fails to meet the standards of practice expected within the Audiology Praxis framework, which emphasizes thoroughness and critical evaluation. Another incorrect approach that involves immediately attributing the atypical result to a specific pathology without considering potential equipment malfunction or patient-related factors is also professionally unsound. This demonstrates a lack of critical thinking and adherence to diagnostic principles. The regulatory framework implicitly requires audiologists to rule out confounding variables before concluding a diagnosis. A further incorrect approach might involve ignoring the atypical result and proceeding with standard audiometric testing, as if normal, which is a direct failure to address a potentially significant clinical finding. This negligence could have serious consequences for the patient's health and would be a clear breach of professional duty and ethical guidelines under the audiology praxis. The professional decision-making process for similar situations should involve 1. Verifying the accuracy of the tympanometric equipment and procedure. 2. Retesting the affected ear to confirm the atypical finding. 3. Considering the patient's case history, symptoms, and any other audiological test results. 4. Consulting relevant literature or seeking peer consultation if the findings are unusual or difficult to interpret. And 5. Developing a differential diagnosis and a plan for further investigation or management based on the comprehensive evaluation. Question 19. Comparative studies suggest that variations in the conchad depth and helix prominence of the pinna can significantly influence the head-related transfer function, HRTF. In a clinical audiology setting, how should an audiologist best utilize this information when assessing a patient with a noticeably asymmetrical pinna structure? Option A. Focus exclusively on the degree of hearing loss measured by pure-tone audiometry, as pinna morphology has no demonstrable effect on the accuracy of these objective measurements. Option B. Recognize that these anatomical variations may impact sound localization abilities and potentially require adjustments to hearing aid acoustics for optimal performance, prompting further investigation into the patient's subjective experience of sound directionality. Option C. Disregard the findings of comparative pinna studies as they are primarily of academic interest and do not have direct practical implications for routine audiological assessments. Option D. Assume that any observed differences in sound localization performance are solely attributable to the pinna asymmetry, and proceed with standard audiological tests without further consideration of other potential contributing factors. The correct answer is B. Recognize that these anatomical variations may impact sound localization abilities and potentially require adjustments to hearing aid acoustics for optimal performance, prompting further investigation into the patient's subjective experience of sound directionality. Explanation. The scenario presents a challenge in audiology practice by requiring the audiologist to interpret and apply findings from comparative studies on the pinna's structure and function to a clinical context. This necessitates not only understanding the anatomical and physiological variations, but also how these variations might impact audiological assessments and interventions. The professional challenge lies in moving beyond theoretical knowledge to practical application, ensuring that diagnostic interpretations and management plans are informed by the nuances of individual pinna morphology. Careful judgment is required to avoid overgeneralization and to recognize when specific anatomical features might warrant a modified approach to audiological testing or hearing aid fitting. The correct approach represents best professional practice because it demonstrates a commitment to evidence-based practice and patient-centered care. By considering the implications of comparative pinna studies, the audiologist is actively seeking to understand how individual anatomical differences might influence audiological outcomes. This aligns with the ethical principle of beneficence, ensuring that the patient receives the most appropriate and effective care based on a comprehensive understanding of their unique physiology. Furthermore, it reflects a proactive approach to identifying potential challenges in audiological assessment, such as sound localization difficulties or issues with hearing device acoustics, and developing strategies to mitigate them. This approach is consistent with professional guidelines that emphasize the importance of considering all relevant factors influencing hearing and communication. An incorrect approach that focuses solely on normative data without considering individual pinna variations would be professionally challenging because it risks misinterpreting test results or providing suboptimal management. For example, assuming a standard pinna shape could lead to inaccurate predictions of sound localization performance or inappropriate selection and fitting of hearing devices, potentially failing to optimize acoustic gain and directionality. This could be considered a failure to adhere to the standard of care, as it neglects a potentially significant factor influencing audiological outcomes. Another incorrect approach that dismisses the relevance of comparative PINA studies altogether would be professionally unacceptable. This would represent a failure to engage with current research and a lack of commitment to continuous professional development. It could lead to a rigid and potentially ineffective approach to audiological practice, failing to adapt to new knowledge that could improve patient care. Ethically, this could be seen as a failure to uphold the duty of care by not utilizing all available relevant information to benefit the patient. A further incorrect approach that might involve making assumptions about functional implications without direct evidence or clinical correlation would also be problematic. While comparative studies provide valuable insights, their direct translation to individual patient function requires careful clinical validation. Making broad assumptions without considering the specific clinical presentation could lead to misdiagnosis or inappropriate treatment recommendations, potentially violating the principle of non-maleficence. The professional decision-making process for similar situations should involve a systematic approach. First, identify the core clinical question or challenge. Second, review relevant literature, including comparative studies, that might inform understanding of the underlying anatomical or physiological factors. Third, critically evaluate the applicability of the research findings to the specific patient's presentation, considering individual variations. Fourth, integrate this knowledge with clinical assessment data and patient history to formulate a diagnosis and management plan. Finally, continuously monitor patient progress and adjust the plan as needed, remaining open to new evidence and clinical insights. Question 20. The performance metrics show significant deviations in the patient's auditory cortex processing, including delayed neural responses to speech stimuli and reduced neural synchrony in response to complex auditory patterns. Considering these objective findings and the patient's reported difficulty understanding speech in noisy environments, which of the following represents the most appropriate next step in audiological management? Option A. Prescribe a higher gain hearing aid fitting without further investigation into the specific nature of the cortical processing deficits. Option B. Refer the patient for a neurological evaluation to rule out central auditory processing disorder without considering the potential for audiological intervention. Option C. Advise the patient that the observed auditory cortex function is within normal limits for their age and suggest no further intervention is necessary. Option D. Recommend a personalized auditory training program designed to enhance neural plasticity and improve speech and noise processing, based on the observed cortical processing patterns. The correct answer is D. Recommend a personalized auditory training program designed to enhance neural plasticity and improve speech and noise processing, based on the observed cortical processing patterns. Explanation. Scenario analysis. This scenario presents a professional challenge because it requires an audiologist to interpret complex auditory cortex function data in the context of patients' subjective experience and potential treatment outcomes. The challenge lies in bridging the gap between objective neurophysiological measures and the patient's functional hearing abilities and quality of life. Misinterpreting these metrics could lead to inappropriate diagnostic conclusions, ineffective treatment plans, and patient dissatisfaction, potentially impacting the audiologist's professional standing and adherence to practice standards. Correct approach analysis. The correct approach involves integrating the performance metrics of auditory cortex function with the patient's reported hearing difficulties and the established evidence base for audiological interventions. This aligns with best professional practice as outlined by the Audiology Praxis regulatory framework, which emphasizes a holistic, patient-centered approach. Specifically, requires the audiologist to consider how observed patterns in auditory cortex processing, e.g., altered temporal processing, impaired speech and noise perception, or atypical neural synchrony, directly relate to the patient's reported challenges in understanding speech, localizing sounds, or experiencing auditory fatigue. The audiologist must then consider interventions that are supported by research and are likely to address these specific functional deficits, thereby improving the patient's overall auditory experience and communication effectiveness. This approach is ethically sound as it prioritizes patient well-being and informed decision-making. Incorrect approaches analysis, focusing solely on the objective performance metrics without considering the patient's subjective experience, is a regulatory and ethical failure. The Audiology Praxis framework mandates that audiological care be tailored to the individual needs and concerns of the patient. Ignoring subjective reports leads to a depersonalized approach, potentially missing crucial information about the impact of hearing difficulties on the patient's daily life and communication. Another incorrect approach is to recommend interventions based on the performance metrics alone, without consulting the current evidence base for their efficacy in addressing the specific auditory cortex function deficits observed. This violates the principle of providing evidence-based care, a cornerstone of professional audiological practice. It could lead to the use of unproven or ineffective treatments, wasting patient resources and potentially delaying appropriate care. Recommending interventions that are not directly related to the identified auditory cortex function deficits, even if they are common audiological interventions, is also professionally unacceptable. This demonstrates a lack of diagnostic reasoning and a failure to connect the objective findings with the proposed solutions, thereby not addressing the root cause of the patient's difficulties. Professional reasoning. Professionals should approach such scenarios by first thoroughly understanding the patient's reported symptoms and their impact on daily life. This should be followed by a comprehensive audiological assessment, including objective measures of auditory cortex function. The audiologist must then critically analyze the relationship between the objective findings and the subjective reports, drawing upon their knowledge of neuroaudiology and evidence-based practice. The decision-making process should involve formulating a differential diagnosis, identifying specific functional deficits, and then selecting interventions that are most likely to address these deficits and improve the patient's functional hearing and quality of life, always in consultation with the patient.